This week on the BackTable podcast.
My main message would be we're learning a lot more about how to manage biochemical recurrence after radiation and local failure after radiation. There's a lot of options available now. And you heard the discussion between me and you. We didn't mention just putting the patient on ADT, right? And I think that used to be kind of the default in many ways. There's a lot of registry studies that said that's what we did. I think that should be really low on the totem pole. And so that's my main message. I don't think these patients should be reflexively placed on ADT. I think we should have a discussion with the appropriate people who could deliver a local therapy and also think about surveillance, of course. But ADT itself is not a benign treatment, and we don't want to necessarily put people on that if our goal is to avoid morbidity.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. Now, a quick word from our sponsor. This discussion is brought to you by Veracyte, provider of the Decipher Prostate Genomic Classifier. Decipher Prostate is a test for patients with localized prostate cancer that can help personalize treatment. Every patient and their prostate cancer is unique, and Decipher Prostate can provide meaningful insight into the aggressiveness of each individual's patient's tumor. Because the Decipher score is derived solely from the genomic characteristics of the tumor, it provides information not available through already known clinical and pathologic factors. Decipher high-risk patients generally benefit from earlier or intensified treatment, while Decipher low-risk patients may be ideal candidates for monitoring or less overall treatment. Decipher Prostate is the most validated gene expression test in localized prostate cancer, with level 1 evidence in national clinical practice guidelines and more than 70 peer-reviewed publications, including more than 65,000 patients. Visit Veracyte.com/Decipher to learn more. Now, back to the show. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Amar Kishan, a professor of radiation oncology at UCLA. Amar, thanks for coming on. How's it going today?
Absolutely. Thanks so much for having me. It's a pleasure to be back.
Well, the pleasure's all mine. You know, your episode on favorable intermediate risk prostate cancer was comprehensive. It was thorough. Actually, one of our most popular episodes. I actually shared the one that you, Neil, and Dan Spratt did on favorable, unfavorable, and high-risk prostate cancer with the radiation oncology residents here at UCSD, and they loved it. So, looking forward to picking your brain today on evaluation and management of patients that have a biochemical recurrence after radiation therapy. I think this is a somewhat feared clinical entity for patients, for urologists, for radiation oncologists. So hopefully over the course of our time today, patients that have been deemed appropriate for treatment, they've met, relevant parties and have elected for radiation therapy. Can you just talk a little bit about how you counsel patients on risk of biochemical recurrence? Maybe we could split it up by favorable, intermediate risk, unfavorable, intermediate risk, and high risk.
Yeah, absolutely. So, of course, the risk in the name even kind of refers to the risk of biochemical recurrence in part of how it was originally defined so many years ago. So I would say, for a patient with a favorable intermediate risk prostate cancer, we quote 7-8 year biochemical recurrence rates of around 5-6%. For unfavorable intermediate risk, increasing up to 15% or so, and for high risk can be as high as 25% or more. Of course, for patients with definitive radiation, when you're getting into high-risk prostate cancer, unfavorable intermediate risk prostate cancer, you're also adding ADT to the mix. And so that's assuming, full compliance with the ADT regimen. Sometimes patients don't take the full ADT, and then the risk of recurrence might be higher. And then, as you're well aware, and as we talked about last time, sometimes there's a lot of heterogeneity between patients, even in the same so-called risk category. So it could, a Gleason 10 prostate cancer, for instance, high risk would have a lot higher chance of biochemical recurrence than, say, a Gleason 8. And so I tried to kind of discuss this in full detail with the patient up front and discuss, how we follow the PSA. I think that's something very different than surgery, right? Where with surgery, the PSA should be 0 after radical prostatectomy, whereas after radiation, that first PSA we check 3 months later, sometimes, I'm thrilled when I see a 50% decline, but the patient might have expected it to be 0 because they didn't internalize the discussion we had. And so It's a lot of it in follow-up is reassurance that if the PSA is trending in the right direction, it kind of does decrease exponentially after radiotherapy as opposed to kind of immediately going to zero.
Yeah, I think that sounds about spot on. I think there's risk factors, the grade group, the clinical stage going into it that nearly certainly make a impact on things. What about some of the more nuanced features, cribriform, introductal, or those things like when you're kind of adjusting the knob, let's just say for anybody in a given risk category that you're like, man, this has kind of got me nervous?
Yeah, so those things to me, are things that if I see in a patient with intermediate risk disease, but then there's some introductal pattern kind of thing that I would say, we really need to add androgen deprivation therapy to your treatment. And, that's one of the main discussions that we have as radiation oncologists would be kind of trying to work with a patient on whether they truly need ADT or not. Obviously, that's one of the most feared parts of the treatment beyond even the radiation itself sometimes. And so when I see aggressive pathological features, that plays into maybe adding hormone therapy or prolonging it in order to make sure that we minimize the risk of biochemical recurrence.
And then if a patient were to ask you, Doc, what should happen to my PSA after radiation? And maybe just to give some structure to it, no ADT, 4 to 6 months, 18 to 24 months. What's the response to that question?
Sure. So it's going to be kind of a decline over time, kind of going down exponentially, meaning it goes down a lot in the beginning and then slower and slower and slower, but should keep going down. Ultimately, we would like the PSA to be less than 1.0. Certainly, if possible, the lower the better. We've looked at this, so less than 0.5 would be ideal, but it can take time to get there. Sometimes it can take 2-3 years to get to that level of PSA. The very first PSA, I like to see a 30 to 50% decrease. And then, after that is a slower decrease over time.
So there's some variability to it. And then obviously, if they're on androgen deprivation, you would expect it to really nadir at close to undetectable. Is that about right?
Exactly right. So if we had ADT on board, we'd want the PSA to pretty much ideally go to undetectable or at least less than 0.09. There's a nice study out of Memorial Sloan Kettering that looked at kind of 0.09 as a good biomarker for response to ADT. And then the thing that we always need to remind patient of is that once testosterone starts to recover, that PSA is going to start creeping back up. And that's not necessarily a recurrence. That's expected because the normal residual prostate tissue remains in this case. And so we would see a pattern where the PSA goes to zero, is staying zero for a long time. Everyone is happy. Then as testosterone starts to recover, it tricks up a little bit. That can cause a little bit of anxiety. But again, that's expected. We follow the rate of increase, and hopefully we would see it kind of plateau around 0.5 or so at that point if they've been on long-term ADT or lower.
Yeah, and you mentioned, these levels, if it gets below them, we're starting to feel pretty good, obviously, especially if they're androgen deprivation therapy naive. There was a presentation that I thought was pretty provocative at ASCO recently. Prof. Ravi was a great presentation from the MGH group, Dana-Farber, where we were seeing these ultra-low levels that were predictive of a biochemical or recurrence-free state. And I think the threshold was pretty darn low. Any thoughts on that? And I guess the question really is, when can you tell a patient that you're pretty confident that they're more like in the biochemically cured end of the spectrum?
Yeah, that's a great question. Yeah, that was work, I think, from the IceCap group, so with Chris Sweetie as well, and they basically had individual patient data from a lot of different trials, and we're showing kind of the benefit of achieving a low PSA nadir within 6 months of the definitive therapy. I think to keep in mind, a lot of those patients did have androgen deprivation therapy on board, and so in the case that a patient's treated with hormone therapy and radiation, and we're not seeing a good decline in PSA, I think there we're actually picking up more aggressive castrate-resistant clones within the prostate, and that's always going to be poor portender for potentially a bad outcome. And I think in those patients, what we need to be thinking about is intensification of the systemic therapy. But I mean, I agree. I think it's a good marker. As far as, when is a patient cured? I think that's a fascinating question. We're doing some research on this as well. I think canonically, We say 5 years is when you're cured, right? And for these patients with prostate cancer, the prostate cancer is not going to be their cause of passing away. They have many years of life to look forward to. We know that if a patient has not experienced a biochemical recurrence by 5 years, the chance of developing a distant metastasis after that, kind of pulling all risk groups together, is only 3%. So that's kind of a great landmark to get to. Our group is kind of working on, can we find a better time point, an earlier time point, because 5 years is a long time. But I would say, I tell patients, we follow you and through 5 years with fairly regular PSAs, like Q3 months for the first year and then Q6 months through year 5.
My post-prostatectomy patients and radiation patients that I follow are like, Doc, when am I cured? And I feel bad hedging because I don't want them to be in that small proportion of patients that have a late recurrence, which is not dangerous typically. But that's what I tell them. I was like, the further out we get, the likelihood of you having a dangerous recurrence becomes lower and lower. Do you think that's accurate, applies to radiation as well?
Absolutely accurate. A couple of groups have published on this, including ours. The time to recurrence is a very powerful prognostic marker. The patients, unfortunately, that have a short time to recurrence, that means more aggressive disease. It's kind of intuitive, right? So, yeah, I agree with you. If someone is disease-free by year 3, their chance of a recurrence is probably very, very low. At that point, it may not be completely less than 5%, but it'd be pretty low. And I think we'll figure out what a good marker is. But yes, the longer you are from your treatment, that disease-free, the better the outcome is going to be.
And are there any features off the gates when you're considering a patient for radiation where you're just like, this is not going to respond? I mean, if it's neuroendocrine features, super low PSAs, kind of an anaplastic, non-PSA producing, are there any patients where you're just like, either published or in your experience, you're like, this patient is destined to have locally radio-resistant disease, I don't think it's worth it?
That's a great question. I don't think there's a great imaging predictor of that per se. You could argue, a younger patient with a very bulky prostate tumor, there could be some intuitive benefit to having that removed completely for debulking as part of a multidisciplinary approach. That patient may ultimately need postoperative radiotherapy, but that could be a situation. There's some data about things like P10, P53 mutations that might not respond as well. I don't think we have that fully fleshed out. Yeah, I mean, in general, for a small cell carcinoma, I think we need to investigate different types of treatment parameters than the standard RT plus ADT or RP in those cases. But for a low PSA, high-grade cancer, I think my main concern, obviously we treat the local prostate, but could there be micrometastatic disease in that type of an aggressive situation? And again, looking maybe to systemic therapy intensification, maybe adding a second generation androgen receptor signaling inhibitor or some other thing to the mix.
Makes sense. And I'm not aware of something along the lines of if you see X, Y, or Z, it's a relative contraindication. How about specifically when you're talking to patients about recurrence risk and the risk of a local recurrence?
Hey, that's a great question. I think it's very timely because my personal feeling is that we didn't appreciate local recurrences after radiation as much as we do now, because now we have PSMA PET, which has been a real game changer. So, just as a historical context, we used to say the definition of a recurrence, the so-called ASTRO definition, was 3 consecutive rises in PSA, and then you can backdate that, and that would be the time of recurrence. And people realized that might pick up a lot of non-aggressive recurrences, and also, someone coming off of ADT will, of course, have consecutive PSA rises. So they kind of convened a meeting in Phoenix and made the Phoenix definition, which was the nadir plus 2 nanograms per milliliter, and that would be the definition of recurrence. It was understood that actually undercalled recurrences, but maybe it was more prognostic for long-term, outcomes like PCSM and the incidence of distant metastasis. But the issue is, I think that's a very high number. So 2 nanograms per milliliter is a high PSA. If I have a patient that had a PSA that responded, it was 0.5, and then it starts increasing, I don't feel that we need to wait till it's 2 to be able to embark on kind of scans to try to see if it's there. But for a long time, even in that situation, we wouldn't be able to find anything. Now with PSMA PET, which is a much more sensitive test, we are seeing intraprostatic recurrences at lower PSAs. There's great data on this out of India. our group has published on this, that you can see PSMA positive recurrences within the prostate at PSAs less than 1. So overall, I think that local recurrences after radiotherapy are something we're going to deal with as a field more and more. Maybe younger patients are getting radiation. We have the PSMA PET. Thankfully, patients are living longer. Used to be, someone might say, local recurrences after radiation, not something that we have to worry about necessarily as much. I don't think that's the case. I think we do need to be aware that that's a possibility. And anytime I have a patient that has a rising PSA that I'm concerned about, whether it's met the Phoenix criteria or not, I get an MRI of the prostate, and I also do get a PSMA PET. And I'm fairly aggressive about referring to my colleagues in urology, Wayne Brisbane, Lenny Marks, to do kind of a targeted biopsy, and maybe not just targeted, I don't want to say just targeted, but targeting the lesion of concern and then some areas around it as well, just to work up whether there is a recurrence or not.
Totally. So a couple of thoughts. I think even on the post-prostatectomy side, which allegedly should be more black and white, these historic definitions of 0.2 are also becoming a little bit more outdated, as we know that bringing in radiation therapy in an earlier fashion is probably better than late. It doesn't feel totally right and something that you're worried about, quote unquote, to not initiate a due diligence survey and local assessment with an MRI and a PSMA PET scan, as you mentioned. And, one of the things that jumped out to me was the FLAME study, which of course you're familiar with, where basically it was, conventionally fractionated radiation versus conventional plus boost. And the local recurrence rates in the conventional, well, backing up the positive arm, the boost arm, they did so well. It's like amazing without worsening toxicity. That's a good thing. But then it kind of makes you wonder, like, oh my gosh, all these people that have been treated with conventional radiation for God knows how long, what's going on there? And does it even matter? Any comment there?
Yeah, I mean, even I guess, in the FLAME trial, right? Obviously, the boost is helpful, and there's been a lot of studies out of Canada, Europe that have shown that DIL, the dominant intraprostatic lesion, is typically the area of recurrence after radiation. I mean, I do think radiation overall is fairly effective, even if we look at the old studies, like the old RTOG, ERT studies from the 90s, the pooled rate of local recurrence, and this is including patients with like high-grade cancers, is like 20%. 25%. And that was in the era before we had PSA, and a lot of those were pretty screening. So we had a lot of these bulky cancers. So I do think it was, it's an effective treatment, even without this flame style boost. But I think the flip side is we are treating healthier patients. Patients are living longer. We're treating younger patients, and we have these tests to pick out recurrences, whereas before we didn't. And I think there was maybe almost a fatalistic approach to a recurrence after radiation, where he said, well, it doesn't really matter. You're going to pass away from something else. Maybe we'll just do ADT or something like that. But there could be a role for curative definitive therapy. We have technologies both in radiation and in the urology world that can handle these. So I think local recurrence is more important now than it had been before, because we have tools to treat it without terrible toxicity, and we do expect patients to do well. Before, the thing could be, even if you found a recurrence in the prostate, if it was a high-grade diagnosis, you might be concerned there's other metastatic disease, so what's the point of going after the thing in the prostate as opposed to just doing ADT? But now with PSMA PET, we can make sure there isn't other stuff going on, and it may be very worthwhile to go after the local recurrence.
Couldn't agree more. I also think that we're going to learn more about local recurrence risk with the varying types of radiation. Protons, photons, conventionally fractionated, hypofractionated, ultra-hypofractionated, which in my understanding have a slightly different mechanism of kill. If you had to take a stab at it, is it going to look better with SBRT or ultra-short course than it historically has?
I'm an SBRT guy, obviously, but actually, honestly, I don't think so. I think it's going to be the same. Ultimately, it is cell kill, and so far, with a standard dose SBRT, I would expect it to be similar to an extended course of radiation. As you get into maybe some of this, the flame style approach, but in an SBRT context where you're delivering that much higher dose per day, you maybe get into brachy-boost territory, which we do know has less local recurrence. So I think if you're doing like a dose-escalated SBRT, that may be pretty good. But I do want to give the caveat that that hasn't been proven. That's my opinion.
Sure, totally. I mean, I don't think the data exists. Mandatory biopsies, which are basically gone, and it'll take a while. And maybe this dovetails in quite nicely into the natural history. So we've started kind of talking a little bit about biochemical cure, biochemical recurrence, maybe just some practical things here. First, PSA post-radiation. When is that? 3 months typically after the last radiation dose?
Yes.
Followed by followed by urology and APP, survivorship, some combination. What's typically going on there?
I think it probably depends on the practice setting. I know a lot of institutions where the urologist does the follow-up. I prefer to follow my own patients with or without if you want to also follow with the urology, that's totally fine, of course. I like to do a PSA every 3 months and then every 6 months after the 1 year mark through the 5th year.
Okay, and checking Ts if they're on ADT, just so you can kind of track that along with the PSA. Talking patients off the ledge if they've received ADT that, hey, this is expected. It's kind of interesting. I can imagine it's challenging for me to totally wrap my brain around it, and for a patient to say, your prostate's been irradiated. For all practical purposes, the tissue should be destroyed. But we still see, PSA, they can develop UTIs or prostatitis or inflammation with spikes in the PSA. There's a PSA Bounce, which I'd love to hear a bit about. The timing of cell kill after radiation, layer in the different modalities. I mean, I guess it could be confusing to a patient. And maybe I would just ask, how do you break that down to the patient, like all these things?
Yeah, absolutely. I guess the radiobiology kind of explanation at a patient level would be, the way the radiation kills the cancer is it damages the cancer's DNA. And I explain to patients that cancer DNA has kind of gone crazy and tells the cancer to grow and divide. The way that radiation kills the cancer by damaging the DNA is when the cancer tries to divide, the cell dies off. It's, you and I know that's called mitotic catastrophe. With a rapidly dividing tumor, that happens fast. And I explain to patients how prostate cancer doesn't divide that rapidly. So what we've really done is we've sterilized it. So if it tries to divide, it will die. But that's what's accounting for kind of that exponential slow decline over time. It's because the prostate cancer itself isn't so rapidly dividing. But you're absolutely right. It's a delayed cell kill. As for why the normal prostate kind of survives the radiation to some extent, we don't know fully why. Clearly, there is an effect because the PSA goes way down, right? It should be like 0.5 or something. And then in terms of a consequence of the patient, oftentimes there's a very low volume of ejaculate, kind of which is telling us that the prostate is not fully functional anymore. But it doesn't go to zero because it has been fully removed. And you brought up a great point about the bounce. I didn't mention that before, but that's essentially what we think is an immunological phenomenon where there's some kind of inflammatory cascade that causes a release of PSA, but that's totally benign in nature. And that's pretty frequent, actually. It's a lot more frequent than we might think. And so that's a situation in which, the PSA has been kind of responding well, and then median of 18 months later, it starts to rise again. Typically, they're small magnitude, so, it shouldn't be to the level of a BCR, which is the nadir plus 2. But it's concerning. Patient's going to be a little concerned that it goes up a little bit. Usually advise, let's do one more check in 3 months. If it's still going up, we can do the scans that you want to do. And likely there won't be anything there. And if the scans are reassuring, I don't pursue it any further than that.
Perfect. No, that's super helpful. And I guess you would think that the normal prostate tissue, the normal cells that don't have any aberrant DNA might be a little bit more resilient to the radiation because they could go through, repair without any issues or problems and survive. And then you got your age-related BPH and so forth. And, your PSA slowly trickles up, but it's not a problem. All right. So you kind of mentioned a little bit about the workup. I think you've mentioned some of the things that catch your attention: doubling times more than 3 months, a quick biochemical recurrence less than 2-3 years. So if you're suspecting a biochemical recurrence, and I'm happy to share what I tell patients, it's kind of based on famous paper in urology, the Charlie Pound paper. It's probably a little bit outdated because the types of patients that we're treating and how we're staging patients after recurrence is different. But I'll say, listen, first off, we're not going to freak out. You're going to be okay. If we did nothing, 8 years on average until you develop a recurrence, and if we continue to do nothing, another 5 years till you die of prostate cancer. We're not going to sit around doing nothing, but it's not time to, get your papers in a fair because we've got years and years to get this handled. So that's kind of my let's decrease the temperature in the room for a biochemical recurrence. If you're pretty certain they've had a recurrence, and I, all comers, putting some of the Gleason score, timing, et cetera aside, how do you kind of break that to patients?
Yeah, much the same way for all comers, I know it's concerning. It's always obviously anxiety provoking to hear that you have a recurrent cancer. But yes, I would say, your chance of dying of this cancer is still in the very, very low single digits. We have a lot of potential management options available. I do tailor it a little bit based on some of the stuff you said to set aside. Maybe if it is a rapid recurrence of an aggressive prostate cancer, it'll probably be a lot more hands-on and say, okay, we do have to act on this now. But a lot of reassurance if it's a less aggressive prostate cancer.
Okay. And yeah, I totally, time to recurrence, all those things, patient comorbidity, life expectancy. It's not just like a reflexive. All right, so you're suspecting it, nadir +2. If there's something that's got your attention, younger patient, quicker recurrence, maybe you pull the trigger on a evaluation. If I'm hearing this correctly, it's an MRI of the prostate, makes perfect sense. It's a PSMA PET scan, also makes perfectly good sense. A biopsy, we do the exact same thing. We do, kind of standard template biopsy plus lesion-directed biopsies and then halo mapping biopsies in the event that we're going to be considering focal therapy and so on. Any gene expression classifiers, any secondary cancer screening tests, any other tools in your toolkit that you're using at this point?
I think those are the main things at this point. Stuff like the gene classifier, like Veracyte's Decipher test and other stuff, they aren't as well validated in the recurrent setting, so don't really go to that. And unless the patient has some kind of very aggressive cancer, originally we're not necessarily doing genetic or germline somatic testing at that point yet. It'd be different again if it's like some kind of Gleason 10 cancer that has come back very quickly. We may do like a somatic mutation testing or germline testing for DNA repair mutations, etc. But otherwise, no. I just imaging and biopsy.
Got it. And how do your pathologists actually read this out? Graded, ungraded, treatment effect?
Yeah, it's a good question. They typically do provide a grade. If we see treatment effect, we tend to treat that almost as not positive, right? Because that could be a case in which maybe there's a bounce that's driving the increase in PSA, and that's something we may follow differently than if there's an actual positive biopsy. So it is hard to give the Gleason grade after prostate radiation, but our pathologists have been giving Gleason grades.
I think it's helpful. I mean, it may be caveated that the accuracy is a bit off since it's post-treatment, but it's, when we talk about management, I think it's very helpful. False positives, biopsies done a little early, somebody got nervous. Do you see that at all?
We do see that. I kind of view that as a good thing, right? That just means that we did our due diligence and it's not a recurrence, right? And everyone tends to be happy with a false positive biopsy.
Okay. So we've documented, let's just stick to localized recurrence to keep this somewhat digestible. They've got a couple oligomets. This can really veer off. But maybe just, so you talked a little bit about your kind of natural history, all-comer talk, which I find to be very useful. Maybe a comprehensive tools in your toolkit, surveillance, watchful waiting, all the way up through salvage prostatectomy. How are you kind of, when you give them their first pass of, here's some of the things we may do, we're going to get the gang together, get a multidisciplinary team. But what does that first conversation look like?
Yeah. So, I would tell them, that we have a couple of different options. Broadly, one is a surveillance-based approach. We're going to just continue following the PSA, maybe repeat imaging. If it remains localized, don't necessarily need to intervene. And that, an older patient with other comorbidities, and maybe if they already have a lot of toxicity from the prior treatment, maybe that's one way to go. But a lot of my patients do prefer a little bit more of an aggressive treatment, particularly if they're younger. They kind of want to move with something a little bit more definitive. We review all of our cases at our tumor board. I refer to urology. I mentioned I've worked very closely with Lenny Marks and Wayne Brisbane here. They kind of run the focal therapy program, but also in general do a lot of the radiorecurrent biopsies with a PSMA MRI fusion. So they already have met the patient probably at this point. But broadly speaking, I would say the options are re-irradiation, some kind of a energy-based ablative treatment like a HIFU or cryo, which typically would be focal, and then salvage radical prostatectomy, which is less commonly pursued, but is obviously an option.
And then with the re-irradiation, historically, it was brachytherapy. We're starting to see some reports of other modalities. Can you talk a bit about that? Your experience, if you have some?
Yeah, so we both SBRT and brachytherapy options. HDR brachytherapy, which is kind of the temporary placement of catheters into the prostate for kind of low number of fractions, typically 4 to 6 fractions, is a good option for these patients. It can be done focally as well with CT and MRI guidance. We have SBRT, which doesn't have as long of a history, but does have some good reports. Actually, there was a recent JCO paper out of Norway that had long-term follow-up using 35 gray and 5 fractions for re-irradiation with SBRT with 6 months of ADT. That had really good 5-year recurrence-free survival and pretty good toxicity rates. And then there's LDR brachytherapy, which has been studied in one RTOG multi-center trial. We don't do LDR at our institution, but that's obviously an option as well from the re-irradiation standpoint. I think the key is it is safe to offer repeat radiation in the right patient. So someone that didn't recur within 2 years of their original radiation, they don't have some kind of ongoing grade 2 toxicity from their radiation. It is something to consider, whereas historically, I think it was off the table. I think now we have a lot of data that you can do repeat radiation.
Right. And I mean, I think it's really hard to land on here is like our typical, because it is so patient specific and nuance, where the lesion is, toxicities, anatomy. But I think it's, kind of nice to have these tools still in our toolkit. We approach this basically identically, tumor boards, systemic biopsies, plus the mapping biopsies. And then depending on the totality, it's, do we monitor this or slow play it? Do we think about focal therapy? And it's kind of similar here. We've got the tools, and my understanding of the literature is that the data around cryo is more mature and it may be a little bit better. And then, salvage prostatectomy, young patients, aggressive disease, localized. I do think that remains a part of the armamentarium. And honestly, it doesn't look quite as awful as it did, I think, 20, 30 years ago with, the rectal injury rates and what I'll tell patients is there's about a 90 to 100% chance you're going to be impotent, about a 50% chance of fluid incontinence, but the rectal injury rates, down to 1-2%. So I think we still have to offer it as we're learning more about the patients that could be salvaged with focal, because the last thing we want to do is do something ineffective, expose to the side effects, and not handle the problem.
Agreed.
Fantastic. So this is incredibly helpful to me. And, as we come on here, close to about 45 minutes or so, Amar, any kind of parting thoughts for the listenership?
My main message would be, we're learning a lot more about how to manage biochemical recurrence after radiation and local failure after radiation. There's a lot of options available now. And you heard the discussion between me and you. We didn't mention just putting the patient on ADT, right? And I think that used to be kind of default in many ways. There's a lot of registry studies that said that's what we did. I think that should be really low on the totem pole. I think so. That's my main message. I don't think these patients should be reflexively placed on ADT. I think we should have a discussion with the appropriate people who could deliver a local therapy, and also think about surveillance, of course. But ADT itself is not a benign treatment, and we don't want to necessarily put people on that if our goal is to avoid morbidity.
Yeah, I think the thing that may seem obvious, but it's worth mentioning from my perspective, is this is a team sport. Radiation oncologist, urologist, pathologist, radiologist, nuclear medicine, medical oncology. It really is very nuanced, patient-specific decision, and you're only as good as your weakest link, in my opinion. So assembling a team that's got some interest and expertise is mandatory really to optimize outcomes. All right, Amar. Well, thank you, and appreciate your full comprehensive approach to this. I always love learning about the things that your group's doing over there. It's wonderful to share some patients as well. A true pleasure. So appreciate you coming on the show.
Thanks again for having me.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend.
If you have any questions or comments, DM us at _BackTable on Instagram, LinkedIn, or Twitter.
BackTable is hosted by Aditya Bagrodia
and Jose Silva.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter,
Aaron Bowles,
Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Chi Ding.
Administrative support provided by Jamila Kennebrew.
Thanks again for listening, and see you next week.